Good morning, everybody. This is 11th webinar of Indian Society of Pain Clinicians. This is the only body of formally trained pain physicians in India. And this is our educational initiative for the benefit of all pain physicians and anesthesiology residents who are the future of pain medicine. So, we have done webinars on different topics till now, like the overview of pain medicine, endoscopy, percutaneous spine endoscopy, short sleeve, ultrasound guided interventions and chronic pain, short sleeve. Now, this is the third for the ultrasound guided management of cancer pain, which I am going. I believe that it's going to be a great webinar for the help for the benefit of everybody. So, today's webinar will be conducted by Dr. Chetna Shamshery and myself, and Dr. Siddharth Verma has kindly agreed to moderate the webinar. And we welcome all the coordinators, moderator, and the speakers who have extensively trained and experienced in the use of ultrasound for the management of cancer pain, which is of great agony to the humankind. So I invite Professor Chetna Shamshery to say a few words and then request Dr. Siddharth Verma to moderate today's session. So welcome all once again. Let's start. Dr. Chetna Shamshery.
Thank you, Dr. Anurag. Good morning, everyone. As all of you know that today is third webinar on chronic pain and ultrasound. As all of you know that ultrasound is going higher and higher over the X-rays because it has no any harmful side effects, and it also captures the images of soft tissue very well. So it plays a very important role in the chronic pain management and minimally interventions, pain and spine interventions. So today, today's moderator is Dr. Siddharth Verma. He is a very enthusiastic and dynamic pain physician. He has done his PDCC from BSU, and now he's a consultant pain physician at D.Y. Patil Medical College, Navi Mumbai. And he is also running a Mumbai Pain School about the chronic pain management, which I'm attending regularly. And I would like to congratulate for this Dr. Siddharth Verma, and please welcome.
So, thank you so much
Dr. Siddharth Verma.
Kind words and for the kind introduction. I thank all of you, my seniors, my colleagues, my guiding forces, to give this opportunity to me to moderate the session. And ISPC is a family which has, I think I have bothered each one of you at some point of time for something or the other. And it's a family wherein we help each other to help our patients in a better way. And pain is a branch which, you know, it's a huge learning every day, and it's changing rapidly. So it's very important that we all be in touch and help each other to learn and teach. And while teaching, we learn ourselves as well. So with these words, I will like to introduce the first speaker of today. And I'll request her to speak on the topic of ultrasound guided stellate ganglion MIPC. So MIPC, as we know that it's a terminology which is well adopted in India. So India is first in the world in this thing, and I'm proudly, sharing this with all of you. We will have some delegates. Right now the attendance is low, but I think some people will join from other parts of the world as well. So this will be taken by my senior colleague, Dr. Chetna Shamshery, who is a assistant professor in Department of Anesthesiology and Critical Care at SGPGI Lucknow. She is one of the initial PDCCs and very knowledgeable and very helping as well. So without wasting any further time, I will request Chetna ma'am to kindly unmute herself and share her screen so that we can start with her presentation. Welcome, ma'am.
Thank you, Siddharth. Is my screen visible?
Yes.
Do you think there is a voice lag?
No, it's completely fine. You can go ahead, ma'am.
So I don't need to switch off my video then? It's okay?
No. Yeah, good. It's good.
Okay. Thank you. Okay. My topic for today is ultrasound guided stellate ganglion MIPSI. I work at SGPGI, where we started doing ultrasound procedures from 2012 onwards, the year that when I started doing my PDCC. So my talk today would be under the subheadings, just few slides related to the anatomy. What are the indications, contraindications, how I do it, complications, and then because this particular webinar is dedicated to ultrasound and cancer pain, so few studies related to stellate ganglion MIPSI for cancer pain, and then in the end, a slide about stellate ganglion neurolysis. So regarding the anatomy, we know that the dorsal and the ventral roots, they come out to form the spinal nerve. And from there, the dorsal ramus and the ventral ramus ganglion nerves, the ramus communicants, they combine to form the sympathetic chain. And this sympathetic chain, it starts from cervical till the coccygeal end. Now this is a cadaveric exposure where you can see the sympathetic chain, it is running on both the sides of the neck. Now in this particular sympathetic chain, you can see some thick knots. So this is the superior cervical ganglion. This is the middle cervical ganglion. And then on the right side, this is the inferior cervical ganglion. Whereas on the left side, if we see, so this is the superior cervical ganglion, this is the middle cervical ganglion, and here the stellate ganglion, which is basically a cervicothoracic ganglion, which is a combination of inferior cervical and thoracic T1 ganglion. So here you see that the ganglion has not united as one particular ganglion. So people do it at the level either of the middle cervical ganglion, which is at the level of C6, or then they come down lower down at C down, where exactly this stellate ganglion is located on the neck of the first rib. So, am I audible?
Yes, madam. You will see your low internet connection on your screen. Whenever you see that, you can switch off your video. When it goes, then you can again switch it on.
Okay, thank you. So I hope I did not miss anything. So this is the cervical and the thoracic ganglions here. They are separated on the left side. Several people, they prefer performing it at the level of middle cervical ganglion, and then several perform it at a lower down level. So what is important here is our area of interest is this particular green triangle, which is the vertebroscaleni triangle. Why is ultrasound necessary for performing a stellate ganglion MIPSI? So the reason is this particular figure. You see this whole circle, this is our area of interest. It is full of vessels and nerves. So a person, if going for a blind procedure or if doing it under fluoroscopy, it is unlikely that we will be able to locate all these vascular structures. And so ultrasound has gained such great importance for performing stellate ganglion procedures. Now, this is a cross section at the level of the neck C6 level. I would just like to bring to your notice 3 facial structures. This is a green fascia, which is known as a deep cervical fascia. I'll not get into the nitty-gritties. In the neck from front, if we go behind, we see this thyroid gland, then we see this trachea, we see the esophagus, which is located more towards the left side. Then we have this carotid sheath, inside which is the common carotid artery, the IJV, the vagus nerve. And then there is this yellow color fascia, which is known as a prevertebral fascia. Now, what is important here is stellate ganglion MIPSI should be performed in the interfacial space. So which interfacial space? We know this is the cervical vertebra. This is the transverse process of the cervical vertebra. This is the longus colli muscle. So we know that usually when we perform it blind, we go from anterior, we hit the anterior tubercle, we withdraw it by about 5 millimeters, and then we deposit our drug to reach into this particular facial plane. Now, it is very difficult under fluoroscopy or when we are performing it blind to exactly locate this interfacial plane. What is the benefit of this particular interfacial plane is that we are not entering into the carotid fascia. So we are away from the vagal structures and the vessels. We are not entering into the muscular fascia, the investing layer of this muscle fascia, because here lies the phrenic nerve. The more deep we are into the muscle or inside the muscle fascia, more are the chances that the phrenic nerve might get involved. So basically, stellate ganglion MIPSI is this particular yellow dot is the stellate ganglion. So stellate ganglion MIPSI should be performed in this interfacial space between the longus colli investing fascia and the carotid fascia. Moreover, we can see there are many structures in the neck to be scared about, to be visualized, and so ultrasound gained its importance for neck procedures. Regarding the indications, because this is a cancer session, so cancer-related neuropathic pain is one of the indications. Post-mastectomy, many patients, they complain of lymphedema, upper limb edema. So in that scene also, stellate ganglion MIPSI plays a great role. Apart from that, for chronic pain, CRPS 1 and 2, herpes zoster, whether it is acute or post-herpetic neuralgia, that is within 90 days or after 90 days, it has a tremendous role. Phantom limb pain or vascular pathologies like Raynaud's vasospasm, frostbite, embolism, or then other conditions are also there which have been reported in literature for refractory chest pain or angina, refractory ventricular arrhythmias, post-trauma, and then hyperhidrosis. So the contraindications for the procedure is patient refusal, sepsis at the site, at the neck site, any active infection. A bilateral stellate ganglion block or stellate ganglion MIPSI should be avoided because of the danger of bilateral recurrent laryngeal nerve and phrenic nerve getting involved. And if an opposite side recurrent laryngeal nerve or phrenic nerve palsy is there, we should be really careful about it, because then we are going to compromise it on the side where we perform the stellate ganglion MIPSI also. Now, there has been this newer technology use of ultrasound. Initially, when we used to perform it through fluoroscopy and through blind procedure, we used to hit the target absolutely AP, anteroposteriorly. Whereas with the help of ultrasound, if we see, the needle does not go absolutely straight, it comes from sideways, so the lateral approach. The lateral approach has very well been favored by in the literature, because there are major blood vessels and esophagus in close proximity to the needle path if we take an anterior approach performed with landmark of fluoroscopy. There is this paper which has come up in 2012. Here you can see Here you can see that in the AP direction, there are so many, many things that are structures that lie in between. And so the esophagus, the vertebral artery, any other artery or a thyroid, there are many structures that can hinder your trajectory of the needle, or that your needle can pierce if you are performing stellate ganglion myopsy in the AP direction. And so it is preferable that we go laterally so that there are less number of neurovascular structures which we pierce. Now, the first publication ever for ultrasonography was done for stellate ganglion block in the year 1995 by Capral S, which was ultrasound imaging for stellate ganglion block, direct visualization of the puncture site and local anesthetic spread. After that, there have been many studies related to blind versus fluoro versus ultrasound. Now that becomes a bit of common sense that blind versus fluoro, obviously fluoro would be preferable because at least we are able to see the bony landmarks. And now there are studies that are coming up, head-to-head comparisons of fluoro versus ultrasound, with ultrasound showing better results. Now selection of the level for sympathetic block, for if you want the pain relief on the neck or the head, it has to be performed at the level of C6. For upper limb, it has to be at the level of C7. Now, how do I identify whether my ultrasound probe is at C6 or C7? So there are three structures which can help us. First is the cricoid cartilage, which usually corresponds to C6 level. The second is the anterior and the posterior tubercle identification. This has been given a lot of credit. If I see on the bony structures till C6, if you see there is this anterior tubercle and posterior tubercle, whereas at the level of C7 there is just posterior tubercle. The anterior tubercle of C7 is missing. So this is how you can differentiate between C6 and C7. The other is the identification of vertebral artery, which lies within the vertebral foramina from C6 and above. But many times, 90% of the times, this does help us. But in 10% of the cases, the vertebral artery, there may be some aberrations, and then it may enter at a lower down level, or it may be exposed even at C6. So basically, in 90% of the cases, it will help us, but it is not 100% reliable. And the last, they say that you can always trace the cervical nerve roots. What do I mean by this is, see, this is C6 vertebra and this is C7 vertebra. In C6 vertebra, this is their anterior tubercle and the posterior tubercle, whereas in C7, there is this posterior tubercle only. You see the nerve roots coming in between the two tubercles. And so you can identify the level by tracing the cervical roots upwards on the neck and seeing when it joins the brachial plexus. So this is one way of confirming the cervical roots. Before I get on to my video, I would just like to brief upon the basic steps involved in ultrasound procedure, so that once I get on to the video, it is comfortable for all of us to understand the basic steps. So first of all, we use a linear probe, which is a high frequency linear probe, 6 to 13 Hertz. A linear probe means visualization of the superficial structures is better. So this is the foot of the ultrasound probe, and we place it horizontally over the thyroid prominence, the thyroid cartilage prominence. So once I put it here, my ultrasound imaging is going to be something like this. So this particular structure is the thyroid cartilage. So you see that the thyroid cartilage is somewhat V in shape. From here, now this was at the level of thyroid cartilage. From here, I bring my probe lower down at the level of cricoid cartilage. Now we know that cricoid cartilage usually corresponds to C6. So I bring my probe downwards. So now do you see this cartilage suddenly changing its shape? And see, it becomes circular in nature. So the V-shaped structure that we see is at the level of thyroid cartilage, and suddenly once I bring my probe down, it will change into a circular cartilage. Once I bring it, the second step was to bring it down to cricoid cartilage. Now to perform stellate ganglion block, we have to lateralize our probe. Once I lateralize our probe, see, supposingly initially my probe was here somewhere, and now I lateralize my probe. Now let me see what all comes below my ultrasound probe. So it is going to be part of this trachea. This shiny structure is the cricoid cartilage, and this particular shiny air and air mucus lining is the tracheal lining. So I see part of the trachea. I should be able to see the thyroid gland. I should be able to see this neurovascular bundle, the transverse process or the lamina. I should be able to see the tubercle. I should be able to see this particular longus colli muscle. So now let's see, when I bring my probe lateral, how does it show to me on the ultrasound? So this is the tracheal shadow. This is the thyroid gland. Then I see the carotid artery. This particular hump-like structure that I see is the anterior tubercle of the C6. And in between the hump and to the cervical vertebra body is the longus colli muscle. So this is the longus colli muscle. Now we know above the longus colli muscle, below the carotid sheath, somewhere here is going to be my area for stellate ganglion block. So this is the anterior tubercle and this is the posterior tubercle at the level of C6. Now, one slide before going on to my video, how to differentiate between the C6 and the C7 vertebra, that is very important. Now here you see the previous diagram, in the previous slide I showed you that these are two prominent structures when I brought my probe lateral to the cricoid cartilage, and these two prominent structures were the anterior tubercle and the posterior tubercle. I have already shown it to you in the previous slide, how in between the two tubercles, the cervical nerve root, it comes out. So this hypoechoic structure, in the video I will demonstrate. This particular hypoechoic structure is the cervical root that is coming out between the cervical nerves that are coming out from the, in between the two tubercles. Now this is the carotid artery. How is this different from C7 level is? See, at the level of C7, we just have one hump, and this is the posterior tubercle. The anterior tubercle is rudimentary. This is the C6 nerve and this is the C7 nerve. So this is the carotid artery and this is the posterior tubercle. This particular hypoechoic shadow seems to be like a C7. We'll get down to it. This is very important. Between the tubercles, you should be able to demonstrate the nerve coming out. And so you are sure that yes, you are in that particular correct place. So now I'm moving on to my video. So as I have already told, we need to use a high frequency linear probe varying between 6 to 13 hertz because it's a sympathetic block involving the neck. Hematoma can be involved. So all airway gadgets should be ready before taking up the patient for a procedure. Now this is my table for the trolley preparation with all asepsis, with my drug, spinal needle, local anesthetic for local infiltration, my ultrasound probe covered fully, and my sterile jelly. We need to cover the ultrasound probe completely to maintain asepsis. Now this is the position of my patient in a sniffing position. Now when I am using a blind or a fluoro, they say that the sniffing position should be tilted towards the contralateral direction also, so as to increase the space between the carotid artery and the anterior tubercle, but then that is not required when you are performing it through ultrasound. A sniffing position might sometimes help in decreasing down the recurrent laryngeal nerve palsy. This has to be your ergonomics. Me, my patient's position, and then my ultrasound machine. Ergonomics needs to be very well maintained when you are performing the procedure and with my trolley. Now this was my assistant. After I position my needle, I just cannot move. Now I place my probe initially on the thyroid cartilage horizontally, the way I showed you in the figure. Unfortunately, this is not a video in video, so that is why I explained all the pictures beforehand. So now this is the thyroid cartilage, which is V-shaped. I bring my probe lower down. over the cricoid cartilage. It has become circular, and now I start moving my probe laterally. This is the trachea and this is the cartilage. So here you see lateral to it, you see this thyroid gland, you see this anterior tubercle, this is the tubercle, this is the body and the area between the tubercle, the longus colli muscle, this is the carotid artery, and this particular muscle is the scalenus anterior muscle. So the plane between the carotid and the longus colli, the fascia in between the two should be the correct position for performing our stellate ganglion MIPC. If I move slightly more, now if I move slightly more lateral, here is the posterior tubercle. So this is the anterior tubercle, this is the posterior tubercle, and this is the scalenus anterior muscle. I need to see this hypoechoic shadow. Just have a look. Anterior tubercle, posterior tubercle, and this particular hypoechoic shadow is the nerve coming between the anterior and posterior tubercle. See this nerve, it comes out. I will also follow this when it joins the brachial plexus. See, it is moving and it is going towards making up a brachial plexus. So this following of the nerve is very important when you exactly locate your, this again enters in between the anterior posterior tubercle. I have come back to my original position. Again, I'm trying to show the, now I have moved my probe down, and now you see, I'll again demonstrate that. This was the anterior posterior tubercle. Now I will bring gradually my probe down at the C7 level. As soon as I come down, I see only the posterior tubercle. This is the C6 nerve. I will again demonstrate it. This is the C6 nerve. You trace the C6 nerve and you bring your probe down. So this remains C6. Once I come down, this is the posterior tubercle. So this has moved away. And then there is going to be another nerve root that is prominent here that will become the C7 nerve. So this is the C6. And here a blinking structure that was seen was the vertebral artery. So see this blinking structure. So we really need to be careful for all the vascular structures that we encompass during ultrasound procedure. So I'm going to perform my stellate ganglion MIPC at this particular level of C7, where I need to take care of all the vessels and all the nerves. This is the carotid. Now here am I see lateral to medial, my needle is entering. And this is the target point of my needle. Now, initially I was slightly intramuscular, then I withdrew my needle. Initially I felt that, oh, my drug is going intramuscular. I withdrew it and then I put it in the facial plane correctly. You have to suppress your neck so that the drug goes down for some time. And then obviously the signs of stellate ganglion block. Okay, so now this was the carotid and this was the longus colli muscle. So just below the carotid, this was my plane of spread of local anesthetic. Again, I would like to bring your attention towards this particular diagram. Outside the carotid sheath, above the longus colli muscle, above the longus colli sheath, above the investing fascia of longus collis is the exact position for the drug deposition. So successful ganglion MIPC is seen by Horner syndrome, myocystosis in ophthalmos, conjunctival redness, nasal congestion, and facial hydrosis. It is also seen if you put a SpO2 probe by an increase in the pulse amplitude. Temperature change is not a definite criteria for efficacy. It has been seen in many studies, although we do say that a change in temperature by 1 to 2 degrees helps you to identify whether your block is successful or whether your procedure is successful or not. Complications, as we know, there are so many structures when we move from anterior to posterior. There are so many vascular structures, so there are chances of hematoma. Esophageal structure, especially when you are performing it on the left side, because esophagus is, I have already shown you that study in which 33% of the cases esophagus was in between the path of your needle. So you really need to be careful for esophageal puncture. Phrenic nerve palsy, not really sure. I will share one study which says that phrenic nerve might not be possibly getting involved. Recurrent laryngeal nerve palsy is invariably seen. If inadvertently you reach into an artery, a seizure, or a vertebral artery, seizures could be seen. because you're so close to the cervical nerves and the cervical nerve roots, epidural injections are common, and brachial plexus injury is also common. Now, this was the study that I was talking about, where they have done the lung function capacity to prove whether there is any involvement of the phrenic nerve after stellate ganglion myopsy. And they have come out with the study that no, phrenic nerve doesn't usually get involved with. They have used about 5 to 10 ml. Okay, so I just forgot the amount of drug that I used. I had used something about somewhere between 3 to 5 ml of local anesthetic if I want to perform a diagnostic procedure. So that was about 0.2% ropivacaine, 3 to 5 ml. So cancer-related pain, many studies have come up where after performing the breast surgeries, mastectomy, or rather modified radical mastectomy, where axillary dissections are done and where there is huge lymphedema or breast metastasis involving the complete upper limb. So in those studies, ultrasound guided stellate ganglion myopsy has been performed. It has been found to have good results. There have been radiofrequency neurolysis or even chemical neurolysis in few of the cases where it has been found to be effective. There is this particular study enrolled in 2018, which is underway. It is RCT of comparing stellate ganglion block for head and neck cancer surgery. We will wait for the results in future. Now that was related to the block where we are using about 3 to 5 ml of drug, because we are so specifically located for, if at all we go for about a blind procedure or a fluoroscopic procedure, we use something between 5 to 10 ml of drug. With ultrasound, you just bring down your drug volume because you're so specific to about 3 to 5 ml. When you are performing a neurolysis, a radiofrequency or a neurolytic procedure, we use curved needle, about 1 centimeter of active tip. Thermal RF has been proven to be more effective than pulsed RF, several studies on that. And case reports have also been seen where alcohol or phenol has been used for neurolysis. So these were my references, and obviously all the articles that I used for references. So with this, thanks for the patience listening.
Thank you very much, Dr. Chetna, and this was a very lucid and very detailed and very simple to understand. You made this procedure very simple, and I could see how much hard work has been done, in preparing those slides. And thank you very much for the excellent presentation.
Thank you.
So it was really great. Thank you so much. And we have some questions, but we will, I think, quickly take a few questions now. The amount of drug you have already replied, 3 to 5 ml. I think that has already been cleared.
And so that this 3 to 5 ml, like there have been various studies now saying that if at all we add an adjuvant to it, the amount of local anesthetic could be decreased down. Supposingly, if we are taking about 3 to 4 ml of just local anesthetic, if we add an adjuvant like clonidine, about 0.5 microgram per kg, then the amount of local anesthetic but
ma'am, can you repeat your last line? You can stop your screen share, and I think you can repeat your last line again.
Oh, sorry.
It's okay, ma'am. Just
is this okay now?
Yeah, it's much better, ma'am. Can you please repeat your?
Basically, it was about, like I said, local anesthetic can be used in between 3 to 5 ml if we are using pure local anesthetic. And if we use an adjuvant, the volume remains the same. It will remain something between 3 to 4 ml only. It is just that the combination goes 3 ml of local anesthetic plus 1 ml of the adjuvant, maybe like 0.5 microgram of clonidine or something like that. So the volume remains between 3 to 5 ml.
Great. And
may I ask a question? First of all, it's an amazing presentation and wonderful video. I have just a single query that first I do it under fluoroscopy guidance only at C7, and I also tend to use 3 to 5 ml of solution. And I rarely see any of the Horner syndrome signs in my patients while using 3 to 5 ml. So how is it like? I would like a word of you, as you also did at C7 with ultrasound guidance, and even then you got all these signs of Horner's.
Okay, so I would say that Horner's sign is usually correlated with, probably I would not question that, but then Horner's sign is usually related with the success of stellate ganglion procedure. So I think so it is, once we are blocking the sympathetic features, and especially at the level of C7, I have always found one or the other features. It is not necessary that all the features are going to be present simultaneously in all the cases.
Actually,
Sometimes,
you are right. Yeah.
Yeah, sorry. You may go answer, please.
Actually, all the conventional literature with the blind state ganglions have been suggesting that unless you get the Horner sign, it is not a successful intervention. But all the pain medicine books suggest that if you do it at, because blindly we tend to do it at C6.
Yeah, right.
Working. And but when we do it C7, so literature suggests, as well as the personal experience, limited personal experience of myself, that we rarely, but patient gets benefited. That doesn't mean that the Horner syndrome, Horner sign is not coming. That means that intervention has been failed. So
Yeah,
I slightly would like to contest this point.
I think the higher we go, the higher are the chances of getting the Horner sign. So I performed it at C7, and at that time I used 5 ml. So few of the features, maybe the drug must have moved upside, because the facial plane is very restricted. If you are bang on in the facial plane, the drug is bound to move even with 3 ml of drug. It moves upwards and downwards to 2 or 3 levels. So if you are exactly in that interfacial plane, even with a lesser amount of local anesthetic, not all, but then some of the features you may find, not all the 5 features of Horner's, some you may find.
Perhaps I think that the difference lies when we do it under Siam fluoroscope at C7 level. And when you, so perhaps we hit the bone and the fluoroscope, we withdraw it slightly and then we inject. So most of the drugs remains in the muscle rather than in the specifically in the facial.
Exactly. Yeah, exactly.
And
that
while
is
you
what
are doing it in the bang on the facial plane, so lesser amount of drug even that goes up and down. And so this is a good thing actually. It has increased my knowledge. Thank you. And Dr. Siddharth, please take over.
Thank you, sir. And that is rightly said that we don't, intentionally try to produce Horners. But if there is Horners, then probably we are in the same plane. That thing is confirmed. That's it. So I think this gives a lot of confidence, because in our procedures, pain relief may be subjective. So if at least we know for sure that we are at the proper plane, and this gives a confidence, especially in difficult cases. So we'll leave it at that. And now let's go to one question. Is there specifically C6 or C7 for USG? So I think it's very clear. It is, you go to the lower level. You identify the, or ma'am, will you like to add something here?
I think there has been a recent literature where I have also seen people rather preferring it at the level of C6. See, vertebral artery is not a guiding criteria. Basically, why do you prefer it at the C7 or why do you prefer it at the C6? You would like to avoid, many a times, you want to avoid hitting the vertebral artery. So with ultrasound, if you are able to visualize it, you are able to safely move away from it. You go it at C6, you go at C7. Basically, if you're in the right interfacial plane, even 3 ml of drug is going to spill over a longer range. So the best thing is, even if you perform it at C6, you need to actually compress it. C6 is better for facial pain. C7, I would say C7, T1, rather people are going lower down to T1 also. It is better for, so if you're in the right interfacial plane, C6 or C7 will not help, but we should always try and go below so as to produce lesser number of complications.
Great. So I think, thank you so much, ma'am. If there are any more questions, we'll take it at this session and if time permits. And thank you for once again for the excellent presentation. And I'm sure even the beginners will be feeling confident to jump over the procedure, but it's better to practice first, under guidance. and then only, you know, try it on your patients. So now we'll move on to the next talk for today. And today we have very interesting talks lined up. And now I will like to invite Dr. Saipriya Tiwari. She is also going to speak on an ultrasound topic, and her topic is ultrasound guided glossopharyngeal nerve MIPSI. MIPSI, I will repeat, is the now recently proposed and accepted nomenclature, which is the origin of, or the gift of India to the world. And I think it's very standard and very logical. And Dr. Saipriya will speak on USG guided glossopharyngeal nerve MIPSI. Dr. Saipriya is a PDCC in pain medicine from the prestigious Sanjay Gandhi Postgraduate Institute at Lucknow. And she is a consultant, currently working as a consultant pain physician at Manipal Hospital, New Delhi. And she will enlighten us with her talk. Dr. Sai, can you just unmute yourself? If you are there, let me just make, okay. So I have asked to unmute. You can unmute yourself. Yes. Can you see the share button in your presentation on your Zoom?
Yes, yes. You have to allow me to share my screen.
So I have allowed you to share the screen. So can you see the share screen option now?
Yeah, it says you cannot start screen share while other participant is sharing.
Okay, you started. Don't worry. You just put on start. It will automatically end. Don't worry. And just select the correct window. Select your PowerPoint in the next window and just click on share. There will be a blue button showing share.
Yeah, you have to stop your share screen for me to say share.
Yeah, so this, there is no screen sharing now. You can, yeah, we can see your screen. You can make it full screen. Yes, very good. We can see your full screen. Now, please begin your presentation. Thank you so much.
Thanks. So, good morning, everyone. It feels really good to be presenting on this platform. And I'm grateful for ISPC for conducting these very, very important sessions for everybody who's practicing pain, not just beginners. So my topic for today is ultrasound guided glossopharyngeal nerve block for cancer pain. Now, glossopharyngeal nerve block is something that you're all very, very familiar with, even as we start our MD, because that is the time that we are using this block in a different way. We are using it to anesthetize the upper airway mucosa for allowing awake intubations and all those things. But my talk today is not at all about the role of a glossopharyngeal nerve block in an OT setting for an awake intubation. This is for a chronic pain situation and a chronic cancer pain situation where the glossopharyngeal nerve is the culprit, or this is the one carrying the pain impulses in our scenario. Now, typically, when do we think of a glossopharyngeal nerve block? When the distribution of pain is this one, as demonstrated in the image. So if a patient is having pain in the posterior part of the tongue, or the pharyngeal, oropharyngeal mucosa, or the tonsillar pillars, or as you can see in the second picture, the posterior part of the pharynx and the mucosa of that area. And the patient says that they are having difficulty in swallowing food. And typically they sometimes say that the pain is radiating into the ear. So this is a kind of pain when we get alerted that glossopharyngeal nerve is the culprit, and that is the one that needs to be targeted. Conventionally, this technique has been done by the peristyloid method. Now, some of you must be aware that peristyloid technique is one of the extraoral techniques of blocking the glossopharyngeal nerve. And this is done near the styloid process. So this is the landmark that we take when we are conducting a peristyloid glossopharyngeal nerve block. Now, people, of course, have done it under landmark technique as a blind technique. Today, what I'm going to show you is an ultrasound guided technique to block it at that level. I'm taking the technique from a study. I came across a lot of case reports, of course, which have demonstrated or have described ultrasound guided glossopharyngeal nerve block technique. I found one retrospective study. So this is the one that I'm going to use to explain the technique to you all. So in picture A or in figure A, you can see that we can very well see the various structures at the base of the skull and just where the glossopharyngeal nerve is exiting the foramen. And the important bony landmarks for us are the mastoid process and the angle of the mandible. So these are the bony landmarks that we take. So in this particular paper, the authors have taken these two bony landmarks. They have placed their ultrasound probe such that the medial end is at M1 and the lateral end of the probe is at the mastoid process. Then what they have done is that they went 1.5 centimeters up to M2. That is how they rotated the probe. So as you can see in this particular section, these are the ultrasound structures that we get to see. So this is the mastoid process. This is the angle of the mandible, and this shiny structure over here is the styloid process. In picture D, you can see all the vessels that have been highlighted on Doppler. And as you can see, very important big vessels are around this nerve. There's ICA, there's IJB, carotid artery, jugular vein, external carotid artery, lots of things lying around here. But we are using the bony landmark of the styloid process. And when we are blocking the glossopharyngeal nerve, we are basically performing peristyloid infiltration of our drug, right? Usually 2 to 3 ml of the drug is enough to cause blockade of the nerve and to achieve pain relief. Now, I'm sure that this seems to be easy, but the problem is that a lot of risky structures are there in quite close to the glossopharyngeal nerve. As you can see, when we are targeting the styloid process and we are going behind the styloid process to deposit the drug, we can see that there is the internal carotid artery, the vein, and a number of other nerves lying around. So there's a definite possibility of injury to the vessels, as well as a possibility of inadvertent local anesthetic spread to the other nerves which are here, which is the vagus, spinal accessory, and hypoglossal nerve. So as a result, we can get a vocal cord palsy or a trapezius muscle weakness or a tongue weakness with this technique. Now, the authors have clearly stated that whichever technique you use, whether it is fluoroscopy or ultrasound guided technique for glossopharyngeal nerve block, and if you inject the drug in the peristyloid area, you just cannot prevent the inadvertent local anesthetic spreading to the adjoining nerves. Because if you're giving a particular volume, there is no plane which is separating these nerves, or there's nothing which is separating these nerves as such. So if you're blocking the glossopharyngeal nerve, there's a very real possibility of going ahead and blocking the other nerves in the vicinity as well. Now, keeping this in mind, a novel technique for parapharyngeal block has been advised, has been described recently, whereby they have targeted the nerve much lower down in the pharyngeal area, parapharyngeal area, where the nerve, turns around just behind the stylopharyngeus muscle and goes in between the plane, which is between the stylopharyngeus and the middle constrictor of the pharynx. I'll elaborate that a little more. So this technique was first described in 2017 on a cadaveric study, which was conducted by Asman and all. So they dissected 5 cadavers and they also did a live volunteer sonoanatomy study on 40 volunteers. And they did ultrasound guided block on a cadaver followed by dissection and visualizing the nerve, which had been stained by methylene blue dye. So what they observed was that most consistently, the glossopharyngeal nerve was visualized at the posterolateral border of the stylopharyngeal muscle, just before crossing to its anterior aspect to reach the pharyngeal wall between the superior and mid constrictor vessels. So this is a parapharyngeal technique for glossopharyngeal nerve block. Now, as you can see in this picture, there are a lot of structures in the picture. So this is anterior and this is posterior. And here, this is the mandible. So if you can appreciate, we are looking at a cadaver from the left side, on the left cheek, if we can say. And this here is the mandible. And another important structure that we need to identify is the hyoid bone, because this is what we use as a landmark. And right about here, this is the stylopharyngeus muscle, and this is the 9th cranial nerve just going behind the border of the stylopharyngeus muscle. So using this landmark, as I told you, the authors conducted an ultrasound guided block. The two important structures which were used as landmark are the hyoid bone, which you can visualize over here, and the pharyngeal wall, which you can visualize over here. Now, hyoid bone can be easily identified. Pharyngeal wall sometimes becomes confusing, but you can confirm that it is the pharyngeal wall by asking the patient to swallow. Of course, in this case, it was the cadaver. But if you ask the patient to swallow, this is going to move. So that is a confirmation that this particular hyperechoic structure is the pharyngeal wall. And this here is the needle. This is the plane just above the pharyngeal wall where the drug needs to be deposited. So this is what they did. And in this case, they injected the dye. And as you can see in the cadaveric dissection, the glossopharyngeal nerve has been stained with methylene blue dye. They also did scanning on live volunteers to study the same, and they could identify these structures very consistently. That is why they have been recommended as landmarks for performing this technique. So this here was the hyoid bone, and this is the pharyngeal wall. Again, hyoid bone, pharyngeal wall. Now, if you put Doppler and see, we can see the facial vessels in some plane. But it is important to note that that is not the plane of glossopharyngeal nerve block. The plane for glossopharyngeal nerve block is deeper to that. So if you're performing ultrasound in that region, in that area, and you're putting Doppler and you can identify the facial artery and the facial vein, please note that the plane for blocking the glossopharyngeal nerve is not that one. It is the one deeper to that, this one. So based on this technique, they proposed that they proposed a reproducible glossopharyngeal block technique at the parapharyngeal level and pharyngeal wall, using the pharyngeal wall and the hyoid bone as the sonoanatomy anchors, which are the landmarks which we always need when we are performing any block under ultrasound guidance. So keeping this technique in mind, I will demonstrate, or I will tell you about one of the studies. This is the first case report which I can tell you, which was published in 2019 of a novel technique of ultrasound guided glossopharyngeal nerve block to relieve cancer pain. This has been published from AIIMS New Delhi, whereby in this particular case, the patient was a 55-year-old man who presented with uncontrolled throbbing and burning pain due to an unresectable cancer of the posterior 1/3 of the tongue. So this is the tumor that they have shown in the MRI. The patient was having severe pain, 10 on 10 on the VAR scale. Best relief oral medications. He was on immediate release morphine and ibuprofen. So this kind of a picture, this case helps us to understand the patient profile or the kind of patient in which this block is indicated. So they conducted a distal parapharyngeal glossopharyngeal nerve block in this particular patient. These are the images from the same study. This is the tip of the needle, and this is the pharyngeal wall. This is the needle, and this is the tip of the needle where the drug was deposited. Now, in this particular patient, the authors say that they got maximum relief for about 1 week. But they also say that the authors refrained from using any neurolytic agents like phenol or alcohol because it has potential side effects on adjacent structures with a potential risk of pharyngeal perforation. So that is why they used only local anesthetic and steroid in this plane. Now, another case that I can demonstrate to you, published in 2020, again done by the team at All India Institute of Medical Sciences, New Delhi. Ultrasound guided glossopharyngeal nerve block at pharyngeal wall level in a patient with carcinoma tongue. So again, the patient was a patient with carcinoma tongue. So this was a 65-year-old male with moderately differentiated squamous cell carcinoma of the left tongue, with severe pain on the left side of the face and oral cavity radiating to left ear and head, aggravating on deglutition. Pain was inadequately controlled with a very high dose of morphine and many other drugs that the patient was taking. Now that the team had already done a diagnostic and therapeutic peristeroid glossopharyngeal nerve block, but it had not given him any relief. So they decided to go ahead and give him a block by this new technique. Again, this is the picture of performing the block on the patient. This is the probe position. This is the patient position of the patient. Patient is lying down supine with his head extended. This is how the, am I audible?
Yes, please go on. Yes, please go on.
Am I? Yeah. And this is the ultrasound image which they have shared, and this is the pharyngeal wall, and this is where the tip of the needle is lying. In this particular patient, they managed to attain relief for as long as 2 months period. Now, this is a very, very new technique, and in literature, I came across only first the cadaveric description and then 2 case reports which have used this technique for glossopharyngeal nerve block. But at the end, I would just like to say a word of caution that the parapharyngeal technique is not as easy as it seems, as we have previously seen in a very, very crisp presentation by Dr. Chetna, that the structures are complex. Now, in her case, the stellate ganglion was much lower. This particular target area is much higher. It is in the suprahyoid area, parapharyngeal area, but there are a lot of other structures around it and nearby. So if any person who is new to pain or anybody who's trying this technique for the first time, it is always advisable to do it under supervision of a senior pain physician and take help from a radiology colleague to identify the correct plane. Styloid or whether it was parapharyngeal, only local anesthetic and steroid was given. I could not find any literature in which people have given phenol or have done a thermal radiofrequency ablation or have done a pulsed radiofrequency ablation by ultrasound guided technique. I'm highlighting this since today we are just talking about ultrasound guided glossopharyngeal nerve block. So whenever these things, whenever these longer term approaches or these modalities have been used like phenol or a radiofrequency ablation, only CT guided and fluoroscopy guided techniques have been described in literature. So with that, I would just want to say that stay home, stay safe, and stay curious. And if you are planning to do an ultrasound guided glossopharyngeal nerve block for the first time, do it under supervision. Back to you, Dr. Siddharth.
Thank you so much, Dr. Sai, for the excellent presentation. And this branch never ceases to amaze me, and you have proven it again with another new technique and another new description. I'm sure many of us, like me, have seen for the first time, and will like to cautiously try it in their practices in future. So with these words, there are no questions in the chat right now. So we will just move on to the next presentation and take the questions together at the end. And thank you so much, Dr. Sai, once again. And now we'll move on to the third presentation for the day. And today for the this presentation, we have another great pain physician, and he will be speaking on ultrasound guided celiac plexus nipsey. So routinely celiac plexus was these procedures were done under the fluoroscopic guidance, but in some cases like if the patient is not able to turn or lie down prone for some time, or in cases where they want a quicker procedure, or in diagnostic cases in many individuals and other indications as well, this new technique has become very popular, and it's not new anymore as well. And I'd like to introduce Dr. Kruti Sundar Mandal, who is the speaker for this presentation. He is a PDCC pain medicine from the Institute of Medical Sciences, Banaras Hindu University, Varanasi. He's a consultant pain physician at the Satsang Charitable Hospital, Deoghar. And today he has some very nice presentation lined up for us. Why nice? Because I have seen the presentation already. And in fact, I am going to share it with you. And I will now request Dr. Mandal to kindly come on the video if he's already there, because I can't see him. Dr. Mandal, please turn on your video so that we can see you. Yes, so you are already the co-host, and I'm going to share your presentation because I have it loaded already. I think you should be able to see my screen now. And Dr. Mandal, I cannot still hear you. Please unmute yourself. Okay, somebody's typed in the chat. I can't unmute. Don't worry, I have put in the unmute button, and you are also the co-host, so you can unmute yourself. Just try and find the Zoom button. If you can see my face, there will be an arrow button on the bottom right. Just click on that and it will make Zoom full screen. Then you can try and search for that. If you cannot find the thing, please rejoin the meeting and unmute yourself. Yeah, I think we can hear you now. Dr. Mondal, you can speak.
Okay, can you listen?
Yes, yes, yes. Yes, we can.
You are audible.
You are very much audible. Thank you.
Okay.
And please switch on your video as well if you want, or you can speak like that only. That's okay with us. If you have some bandwidth issues, we can speak like that only.
Okay. Good morning, everybody. So I am going to speak on ultrasound guided celiac plexus neurolysis. Okay. So next slide, please. So first of all, as Siddharth has introduced, that celiac plexus block is a very challenging one and is very useful for the pain management people. So we should know details about the anatomy and also ultrasonic anatomy and the indications, then what are the complications, and then we'll proceed. So first of all, we'll include those patients. Sorry, previous slide. So we'll proceed. The inclusion patients are mostly we use this celiac plexus block in cases who has cancer patients like cancer of gallbladder patient. Most of the patients will find the GB cancer, and there is some problem in spleen, pancreatic cancer, also in stomach pain, stomach cancer, or upper GI tract cancer. Besides that, most challenging one is your chronic pancreatitis patient. So this is really interesting and challenging one for the intervention pain management patient, pain specialist. So let us see what are the exclusion patients. If patient will refuse to do this, or if there is any coagulopathy, or patient have colonic gas distension, so first we'll refuse it and first prepare the patient, then we can proceed. Next slide, please. Next slide. So this is the anatomy. This is the epi view. Let us see what are the supply of celiac plexus. There is three supply. One is preganglionic sympathetic, that is your greater splanchnic nerve T5 to T9, and there is lesser splanchnic nerve from T10 to T11, and the least splanchnic nerve T12-1. This is the sympathetic supply, and the parasympathetic supply is vagus nerve, that I show it in the right side, and there is also sensory supply by phrenic nerve. And celiac plexus formed at the origin of the celiac trunk from the abdominal aorta, just at the origin of the celiac trunk, and just below the celiac trunk there is superior mesenteric ganglion. So main target is celiac ganglion. This is very important because in the later slide I'll show you that it is important to know where to inject the drugs. So next slide, please. Next slide. Yes, this is the lateral view. As I explained, that greater splanchnic and lesser splanchnic and least splanchnic, they are piercing the crura and enter into the celiac ganglion. They form the celiac ganglion just at the celiac trunk. Next slide. Now we'll see the ultrasonic anatomy. There are we use normally the 2 to 5 megahertz broadband ultrasonic probe to see the structure of celiac ganglion, nearby structure, because here in the sagittal scan, this is your sagittal scan. First A scan is sagittal scan, where we can see AO, that is abdominal aorta. Abdominal aorta is there, and on the left side there is, on the right side there is inferior vena cava. Inferior vena cava, and there is also, and above is liver, right lobe and left lobe, and here is stomach. STO is stomach. So this is the aorta is the most important part. Here you can see SMA, written SMA, that is superior mesenteric artery. In axial view, I will elongate your superior mesenteric artery in the axial view, that you can see clearly this superior mesenteric artery is visible here. But our main target is just above the superior mesenteric artery, not below the superior mesenteric artery. Even if we can go at the just origin of the celiac trunk. And the next slide, please. Here, here you can see this is abdominal aorta, superior mesenteric artery, and here you can see the pancreas and stomach and inferior vena cava. But main target is our at just above the celiac trunk, because below the celiac trunk there is chance to inject in the superior mesenteric ganglia. So next slide. Yes, this is our needle insertion. We'll go mostly on the right side of the patient. We'll keep our probe on just below the epigastrium, just below the just at the epigastrium, and on the right side we'll approach to the this abdominal aorta. Main target is abdominal aorta, and there is first branch. First branch is celiac trunk. We have to first identify the first branch where we can approach to the celiac trunk. Next, what are the advantages? Because as you know that we used to do, as the advantages are, first is, there are three types of procedure by which we can do our celiac trunk plexus block. First one is retrocrural. This is the classical method where by the C-arm or fluoroscopic method, we go, patient will be in prone position and we go on the posterior aspect. This is the retrocrural method. And the second one is transcrural or true celiac plexus block. That is, we go through the aorta, but through the CT scan guided. And last one is enterocrural. It is the approach where we use ultrasound. This enterocrural approach is the true enterocrural approach where you can directly put drugs or do radiofrequency neurolysis over the celiac plexus. So let us see what are the advantages. First advantage is a true enterocrural process. This is the exact position where we can put the drugs. And the second one is, it is most suitable for the patients who cannot lie on the prone position, because in cancer pain patients it is very difficult to lie the patients in the prone position. And the third one is, there is no radiation exposure for the patient also and for the doctor. No suitable for the where there is not suitable for the terminal cancer patients, we can do it on the bedside. So it is also another advantage. And third one, which is a dangerous event which can occur through the posterior approach, like nerve root injury, where there is chance of nerve root injury. Also there is chance to injure the Adam-Hughes artery, which supplies, this is the largest spinal vertebral radicular artery, which supplies to the lower ventral 2/3 of the spinal cord. There may be chance for paraplegia. If there is accidental injury, accidental drug injection, there may be chance of spinal cord ischemia. So it can be prevented by anterior approach. So there are so many advantages, but there are limitations in some cases, like it is a technically challenged. Those who are not technically challenged, they can injure the aorta, and there is chance to injure also the liver and injure the stomach, pancreas. That is the disadvantage. So it should be technically sound. And second one is, in case of distorted anatomy, like cancer patients, where the plexus is covered with the tumor, then it is very difficult to identify. So this is also another difficulty. And third one, sometimes there is a mass anterior to the plexus. Sometimes there may be vascular mass, which can be identified by CT scan or MRI, where there is vascular mass above the celiac plexus. So there may be chance of vascular injury. By the way, we'll do the procedure through this ultrasound method, and here we can use phenol, we can use alcohol, also you can do radiofrequency lesion. Phenol is 6 to 10%, we use mostly use 6 to 10%, but it is useful in posterior approach, because in case of phenol we can combine with dye, that is iohexol we use in the posterior approach. So here we don't need any dye, so there is no role to phenol. But advantage of the alcohol, we use around 15 ml of absolute alcohol, 12 to 15 ml, which is more duration for than the phenol. So we can use alcohol than phenol for the cancer patients to get relief for the more time. And third one is radiofrequency lesion. First we'll do the needling, and then we test it through 50 hertz 2 volt, checking your sensory stimulation. If there is girdle pain, we can see a girdle like sensation, or epigastric pain, patient will feel pain, then it is okay. And the second one is we can test motor sensation, where intercostal muscle contraction will be there. Then after checking the sensory motor checking, then we will confirm, then we'll put the drug. First we will put the 5 ml of 0.5% ropivacaine with some steroid. Then we'll see the result. Patient will tell, yes doctor, I am getting pain free. Then we'll proceed with RF lesioning. We'll do 80 degrees Celsius for 90 seconds 2 times, so that there will be sufficient lesion for the celiac ganglion. And the last one I want to discuss, there is some complications which can occur, so that we have to take precautions for that. There is first complication is hypotension. Since there is sympathetic plexus block, then there will be there is chance of hypotension. So we must ready for that. We should ready for hypotension. There should be fluid preparation. There should be vasopressors. We should ready with that. These drugs, atropine and mephentermine, we should ready with our hand. And second one is GI hypermotility. That is, there may be chance of diarrhea. So we should not be worried about it. We can manage it, diarrhea. And the third complication is pneumothorax. If you pierce your crura diaphragm, there may be chance of pneumothorax. So these are the complications we can under. Now I am going to show you the last slide. How to wait. This is the slide. Here we are putting drug through the right side of the. This is the needle. This slide where we are putting needle, and here you can see the needle and entering into the aorta, nearby aorta. So this is the next slide, please. Next slide. Yes, you can see the arteries around the celiac plexus, and this is the needle. Next slide. Next slide, please. Yes, now I will show the video how we are entering. First, we are entering the skin, superficial fascia, and external oblique muscle, internal oblique muscle, and also transverse abdominis. Then we are entering into the peritoneum, visceral and outer peritoneum. Then just we are entering above the aorta. Here you can see the aorta where the needle is entering. Yes, this is aorta, and this is the needle tip. Needle tip is hereby. Okay, continue please. Yes, continue. Yes, this is the way where we are putting the needle. Here is the channel. From the right side we are entering. Just see. Yes, it is moving towards the aorta, nearby aorta. Now we will inject normal saline first, then we'll see how it is affecting. Just entering the needle. Yes, continue please. Continue. Continue video please. Yes. Let it continue, please. Now needle is entering, and main target is just at the above the aorta, where there is branch of celiac artery. Yes, yes. Needle is entering, and now we are going to inject the drug. Yes, this is the point. Okay. Now needle has entered. Yes. Now we are injecting the drug. You can see the yes, radiolucent area. Yes. Now we are injecting above the aorta and side of the aorta. Now next we are injecting the drugs. Please continue. Yes, please forward it. Forward it. Yes. Okay. Okay, Siddharth. Yes, yes. This is the area. Yes. First, second, and third. Yes, good. Next. Continue. Right side, left side, and above the aorta. This is clearly visible aorta, and by axial view, you have to confirm it whether there is celiac plexus or superior mesenteric artery, because superior mesenteric artery is larger one. Yes, we are injecting the drugs. Continue, please. Yes. Thank you, Siddharth. Okay, so this is the presentation, so that we can try, and I have practiced at least I did 50 to 60 cases, and all are successful. And second thing, if we are using alcohol, and if there is sometimes there is problem with alcohol, if a patient with ascites, mostly in liver cancer patients, any patients, there is ascites, so there may be some problem. We can inject alcohol just above the celiac plexus, and we can see the result. There is less chance of infection because we are using alcohol. It can kill the infection, so don't worry about the infection, and we can proceed, and we can see the result. It's a very fantastic result with these patients, with this procedure. Thank you so much.
Thank you, Dr. Mondal. So this was a very excellent demonstration, and I think you were already done with the procedure very fast. But since you were going to record and demonstrate to us, so you put your needle everywhere and lingered a little longer than what you usually would have been. So thank you so much for sharing your patient and your slides and your procedure with us. And now I will like to invite questions. If any are there, they can be just put in the chat box. Let me check. There is appreciation for size, excellent talk from Dr. Sujit Gautam sir and Dr. Chetna Shamshery ma'am. And indeed, it was a great technique which we learned today. And I think, let me just check if there are any questions. No, I think there are no questions posted till now. So, Dr. Mondal, let me ask you some questions which I want to ask myself. So what needle are you using for this procedure? Celiac plexus.
Yes, I am
Because
using.
it was a connected needle, so I think you are using a needle which is having the connector for the extension tubing, right?
Yes, yes, yes. I am using 22 gauge needle and 20 gauge needle.
And which type of needle is it? Is it a you are using a Quincke's needle? I think.
No, I am using Quincke's needle.
Yes, yes. Okay,
Yes,
this is what I
yes,
thought. Okay, and many people they use a Chiba needle, which is a little blunter, but it's not used by everyone. And somebody has asked, Dr. Chetna has asked, what is the preparation for the patient a night before? Because if you have bowels with air, and the
Yes.
ultrasound then cannot pass through those air things, and you will have, this is a very common you can say issue for especially for beginners. So
Yes.
she has rightly pointed out. So what is your advice for that?
First of all, as I said, we have to first rule out the coagulopathy. Because liver metastasis, there may be chance there is coagulopathy. We have to prepare this patient, or we
Yes.
can reject the patient. And
Yes.
second thing, we have to give dulcolax, like bowel preparation. For bowel preparation, we give laxatives. If there is bowel free, then we can see there will gas will be not there, and it will not interrupt in our procedure.
So what are the what is your protocol for giving
In
the
protocol is first I have to check the vitals and see all the blood parameters.
No, sir. The
If
protocol for the bowel preparation means
okay,
you
bowel
give
preparation I
the
used to give
one night before, or do you do something else, or
no,
what?
one night before. I used to give 2 tablets of dulcolax,
Yes.
and in the morning, if there is no bowel pass, then I used to give enema, proctoclysis enema, and it will sufficient for bowel preparation.
Okay. Thank you so much, sir. And let me see if there is another question. Okay, so somebody is asking, you are actually using the right side of the patient, but somebody has still asked which side is preferred, right or left, and are there any differences?
Because in right side we directly put on the this aorta, because in left side there is chance of injuring to the stomach wall, because in left side, in the right side there is curvature, lesser curvature, so there is less chance to injure the viscera, and as well as in the left side if you enter, there is chance to injure the vessels and also the these viscera. So you should go right side. If there is any distortion by the cancer metastasis, we can also approach to the left side if there is some problem in the right side. In case of gallbladder mass, if it is pushing the aorta, and there is if there is mass in the right side, so you can, if we can visualize the aorta, you can approach through the left side. But mostly I use the right side approach because there is chance to less injury.
The next question is very related. What are chances of bowel injury? And I would like to add, do you give any prophylaxis of antibiotic prophylaxis or prevention against supposedly inflammation or infection?
I used single dose of antibiotics, third generation cephalosporin, nothing else, because mostly I use alcohol. Alcohol itself is an antiseptic. It will kill the bacteria. And second thing, I use at least 1 liter of procedure, 1 liter of saline, so that it will be prepared for uh, this procedure.
So this is the same as we do it for
Spinal anesthesia.
guided, yeah, or any even the spinal one. Okay, thank you. And somebody's asked what is seen here, base of celiac artery or its bifurcation. So bifurcation is not always seen, so better to see the base of celiac artery. So
Yes.
how long the patient has to be in position, the same position before shifting the patient? So this is a pertinent question because you want the alcohol to be fixed to the neural
Yes.
structures. So what do you use in, I mean, how much time do you tell the patient to lie in the same position?
By giving alcohol, there is severe pain. So before that, I use this rupivacan so that patient will be pain-free and comfortable. Then I use alcohol and keep it for 10 to 15 minutes and checking the pulse and blood pressure. Continuous checking for at least 15 minutes.
Okay, great, sir. So I think 15 minutes.
Siddharth, just I want to ask one question from Mondal.
Please go on.
Dr. Mondal, you are saying that in ascitic patient, you are also doing ultrasound guided.
Yes,
But,
yes.
How can you able to do in ascitic patients?
Yes,
We are not
in this case, I use little that patient is positioning so that the head end is upright, and so that fluid will be come down. We can do the procedure. We can easily see the aortic pulsation.
Okay.
So now let's move on to the next question, which is what is the amount of alcohol which you are using, Dr. Mondal, in your patients?
12 to 15 ml.
12 to 15 ml. The next question is will be obviously what is the concentration? I think you're using absolute or you're diluting it.
Absolute alcohol.
So you don't dilute it with local?
No. First I check with rupivacan, then I inject, so that patient is severe pain. If alcohol 0.1 ml is sufficient to give such a pain, patient will wake up. So better to give first local anesthetic, 5 ml of rupivacan, then we'll proceed.
Great. And the next question is from Dr. Chetna. She asks, apart from Dulcolax, have you tried the charcoal tablet?
Yeah, you can try, but my patients are good with this Dulcolax and also proctocrasis anemia.
Okay, enema. Yes. Okay. Thank you, Dr. Mondal. I will request you on behalf of the Indian Society of Pain Clinicians to please publish your data. This is not a small number, and I think you can easily get into some good journal with this data. Okay. And your insights can be very useful to many of the people who are trying to do this procedure.
Thank you. I will definitely.
Dr. Mondal, एक second. What are the most important post procedure complications? Please enumerate for the beginners.
For the beginners, first of all, one of my patients, when I was doing, there was severe hypotension. So be careful and keep prepared with you edge in case of spinal anesthesia. Also, you should prepare with airways because there may be chance of pneumothorax also. So we should prepare both. And the second thing, there is chance of diarrhea. So keep the patient, don't disturb the patient. First observe for 1 day, and second day you can keep the patient. If there is diarrhea, don't worry and give fluids, and patient will gradually improve.
Yes. Proceed, Dr. Siddharth.
So now I think we are done with the session. We are done with the questions, and I will now like to call upon Dr. Anurag and Dr. Sarita. If you want to say the closing word, you can thank all the speakers, and we can end the session. And I personally would like to thank all the speakers, Dr. Chetna, Dr. Sai, and Dr. Mondal for their excellent presentations. And personally, it was very beneficial for me, and I'm sure everyone else has also gained a lot from it. Thank you so much, all of you. Thank you.
Dr. Anurag, before conclusion, I would like to invite Dr. Virendra Rastogi, who is here. Please say a few words, sir. Hello. He was there.
Yeah, I think he was there, but
now he's not there.
Yeah.
Okay.
So we are happy to be blessed with one of the founding fathers of pain in India. I mean, this is his guidance has led us to a lot of good things, and we are fortunate to have very senior teachers also, with us off and on. So I think Dr. Anurag, we can take over, sir, and if you can close the session.
So thank you for all the speakers, especially Dr. Chetna, Dr. Saipriya Tiwari. Today's presentations were very useful for all of us, and thank you for sharing your own
Sound is not
experience.
appropriate. Can you just speak in the mic?
I'm saying that today's presentations were really amazing for all of us, and I thank personally for sharing your own personal experience with all the real problems. And all of you have done extra work to use the ISSP promoted and ISPC supported nomenclature. Dr. Siddharth has correctly mentioned. This is our gift from India to the world about the nomenclature, right nomenclature of the pain medicine and its minimally invasive pain and spine intervention. So, all of you have done a remarkable job in putting or making all the slides, videos, and I thank you all of you. I thank Dr. Siddharth Verma for moderating the session so wonderfully. It's really amazing to see young blood taking over. And I am thankful to Professor Chetna Singh, who has been very busy in some exam, I believe, but still she took out time to join us in this ISPC initiative of education to everybody. And thank you, ma'am. And with this, I
Thank
close the
you.
session of today. And we invite you for another session. We will come back again in a new flow of deliver in a new format. Thank you. With these words, with your permission, I am ending this meeting. Thank you all.
Thank you, sir.
Thank you.